people in developed countries who also have not grounded themselves in systematic reviews. And we're going to see why it is important doing systematic reviewing. So I'll start by sharing my slides, my screen top. Then
brilliant. While the slides are coming up, just announcing that we will be recording this part of the webinar and hopefully the Q&A session. So I hope that's okay, colleagues. But if you have got any concerns, please do text me or email me, and then we'll try to preserve your preferences. Back to you, Tony.
So, as you all know, the main topic is advancing innovative, evidence-informed, demand-driven, and policy-relevant, the contextualized manner of evidence synthesis that would strengthen health systems and improve patient outcomes, because all that we do as scientists is to improve the outcomes of patients and or the public in general. But today we are going to tackle only the evidence synthesis part of it. What is evidence synthesis and what we need to know, because you need to sensitize ourselves. And let me start with the story. The former Secretary General of the UN, Kofi Annan, who passed away, may he so rest in peace, said something that life is full of choices, and to live is to choose. And to choose is, and to choose well is to know where you're going. So unless you know where you're going, it becomes very difficult to choose. So I think that the basis, the fabrics of evidence synthesis is very essential before we even embark on doing a systematic review. And that is exactly what we're going to do today. So the first, I'll have some questions for you. I'm not going to do it all by myself because I have to also get you engaged. So my first question to you is, what is systematic review? People have heard about it so many times. So now I'm asking, if you were somewhere teaching and a student asks you, so what is a systematic review? What would you have, maybe how would you have answered it? So the first question is, what is a systematic review? The second one is, why systematic review? In other words, why do a systematic review after all? And the third one is, what are the types of systematic synthesis or reviews you know? So we're going to now take all of them one by one, but I use another story to start, because I saw that this time it is evening in it's evening in Australia. So people are tired, so it has to start with a story. Nowadays, our patients are enlightened because you're living in a society which is becoming increasingly complex. And because patients are enlightened, the health system delivery has also become complex. And we have to bring in complex methods to be able to deliver to meet the needs of our complex patients. And a case happened in Ghana, one of the suburbs in the second capital in Ghana, Kumasi. A lady, after 9 months of pregnancy, went to deliver. And after the delivery and the recovery, she asked, "Where is my baby?" And they told her, "You had a stillbirth. So your baby died." And he said, "According to my custom, because she's a Muslim, I want to see the face of the baby before you bury it. And then, where is my baby?" No answer. They couldn't find the baby. And it became a big issue. You see this woman over here. She was then the health minister sitting in the capital in Accra, not having anything to do with the health system or delivery in the clinical setting. But immediately she was called to answer questions. Why would that happen? Because she's accountable as the Minister of Health. You're accountable to even the subordinates underground who are working. And why did this thing happen? Because there were no evidence-based protocols and guidelines in place to support reporting and how this event should be reported when it occurred. So this is the first scenario over here. So it means that as scientists, we are accountable to our patients. And the second one is that now we are living in a world which improves information systems and social media. So if you are a clinical practitioner sitting in your practice and waiting for patients, now the patient, before they came to you, they would have already gone to the internet sometime to search on the to have some information about their symptoms before they will come to you. And this happened. A woman self-diagnosis ovarian cancer over internet search. And what happened? Because this woman had visited her GP several times, and then nothing was found. And she kept on experiencing that debilitating event after visiting the GP. So she took it to herself to search the internet. And this also was reported in a Yahoo Mail. And then later on, she diagnosed that she was having ovarian cancer at the late stage. And when she reported back and they did the actual diagnosis, it confirmed that she was having a late stage cancer, ovarian cancer. So what does it tell us? That nowadays, we don't have to be complacent. Our general practitioners and the doctors might not be the only people who know. We should have to listen to our patients. And if we don't become evidence-based or update our knowledge, our patients will come back and tell us the diagnosis. And how would you feel if you're a doctor? I've come to you so many times, and then you couldn't diagnose my condition, and I come back and I show you the diagnosis, and then it's confirmed. It's a bit humiliating. So that one too. Because of the information, social media, things are getting to the hands of patients, and they can confront us if you are not prepared. But this gentleman saw it well coming, and he wrote a book and titled it, The Future of Healthcare Delivery. And then he said, on this paper, this is our TRX, which means treatment, why it must change. That is the future of healthcare system delivery, how it must change and how it will affect you. So he posed this question for us. So the way the society is going, our healthcare system needs to change. And how, if it does not change, how it will affect us. And if it changes, how it will affect us. So there are a lot of it in the book, and I use it to tell you that there are so many scenarios that people were talking about the healthcare system. Then we got to know that from what I've said, patients are looking for evidence, clinicians are looking for evidence, and other people will go back to it. So it means there's growing pressure on reliable evidence to inform healthcare decisions. So all these people, policymakers, patients, and then practitioners are all looking for information because what? They are looking for evidence on the benefits and harms, because we know that not all health interventions have the desired effect. They also have some consequence, adverse events. So if you prescribe something to me, I have to make sure that what I'm going to take is good for me. And the clinician also have to make sure the same. So everybody is looking for evidence. And now this has led to what we call the evidence movement, because patients, policymakers, even funders, researchers, everybody is looking for evidence to inform their decisions. So then evidence movement, what is it? In the health sector, it means that all healthcare decisions should be based on the best possible evidence. Decisions should be taken into decisions should take into consideration the patient's values, beliefs, and preferences. And immediately we talk about that, those who are familiar with this know that we are talking about the genesis of evidence-based medicine. Evidence-based medicine has three core benefits. That when you do evidence-based medicine, when you practice evidence-based medicine, you have to, first of all, the practitioner have to have their clinical expertise in hand to use. The patient values and preferences should be respected. And then the third one is research-based evidence. And that is what we are going to talk about most, because that is the missing link, all that we are doing as researchers. We might not be with a patient to give them the treatment in a GP setting. But what we are doing remotely is what is influencing what the GP is doing, the general practitioner is doing. So if we're able to feed them with the best evidence, they'll be able to do the best things right. If we are not, we think that we are not in the equation, but we are very important in the equation. And when we're able to do that, the outcome is really good. Improved quality of care and patient outcome, improve patient satisfaction, and one thing is that reduce costs. This has been put in a nice way as a Venn diagram, evidence-based medicine. So look at how they are. These are circles, Venn diagram, with an individual clinical expertise. That is the provider, the clinician. And then we're saying that the patient that comes to sit before you in the clinic, you have to respect the values and expectations of the patient. And then the last one is the best external evidence. And when you're able to incorporate all these things or merge them together, that is only when you are practicing evidence-based medicine. So look at it. In so many cases, doctors are not practicing evidence-based medicine, but look at it, the Venn diagram. All this one, they are using their own expertise to sometimes diagnose, but things are changing. It is only this interception that when all three have come together, that is when evidence-based medicine is practiced. And evidence-based medicine has been defined nicely, but I decided not to include it here. But this is a homework for everybody to look for what is evidence-based medicine. The definition, you can have three of them, very important. But this man, David Sachet, was considered the father of evidence-based medicine. He did most of these things when he came as a fellow at the Oxford Evidence-Based Center. And then the main goal of evidence-based medicine is to improve healthcare by narrowing the gap between research and practice. Then the evidence-based medicine information started around early 1990s. And this Sachet and colleagues wrote a paper published in BMJ in 1996, which they titled Evidence-Based Medicine, What It Is and What It Isn't. So they were trying to now bring everything together. What is evidence-based medicine? What is not evidence-based medicine? And as I say, those who are interested in publication, I know everybody likes to publish. You see, this paper has been cited 17,431 times. This paper published in 1996, so it is something that widely cited. And then now, evidence-based medicine again. We are saying that evidence-based medicine requires the best external evidence. And where does the best external evidence come from? We're going to, later on, we're going to look at the pyramid of evidence, but I'm just using it, preempting you over here that the best external evidence comes from systematically synthesized data or evidence from systematic review and other forms of evidence synthesis. So we'll be dwelling on this systematic review. Why we are interested in systematic review? Because it provides the best form of evidence. It distills the whole evidence and gives us the best out of what we put in the distillation channel or distillation tube. So we move on. Now we are talking about systematic review. I've said a lot, but not saying anything about it. Now we come to this stage and I said, then the question that I posed, the first one, what is systematic review comes to? What is systematic review? And you can quickly, if anybody asks you anytime, define a systematic review, this slide alone should be enough. So please take note of this slide. It's a form of secondary research that attempts to collate all empirical evidence, meeting pre-specified eligibility criteria to answer a specific research question by distilling evidence at the highest level possible. It takes everything. It combines everything in this short statement. And what does it? It does not end over there. The process, it uses explicit, transparent, and reproducible methods. So normally I use the word methodical approach to, one, identify studies, to select studies, to critically appraise or assess quality of the included studies for risk of bias in them, extract and analyze the data, report the result in a clear and accessible format, and interpret the findings, considering carefully any flaws in the evidence. So this is what we will be later on. I'll talk about the process of doing a systematic review. We are going to take this one by one, formulating the research question, building your search strategy and searching. And that is where at a point, Judy and Natalie will come in strongly, because that is where we will be talking together when it comes to the search. I will give the theoretical basis and they will help us with the practicals. And systematic reviews involve meticulous effort to minimize bias, thus providing more reliable findings and conclusions. A systematic review may or may not include a meta-analysis. In other slides, I jump immediately into meta-analysis, but this one, no. I'm talking about some attributes of systematic reviews before taking out the meta-analysis part. So high quality systematic review. It means that not all systematic reviews are high quality. And we'll talk about that one too, because systematic reviews are supposed to give us the best evidence possible to inform our decisions. And if they end up not being good quality reviews, what do you think? What do you make of them? It's serious. So we look at it. A high quality systematic review seeks to identify all relevant published and unpublished evidence. This is the search. And sometimes the search has to be comprehensive, because let me take you back. If you go here, it says, collate all empirical evidence. So you attempt to locate every study that meets the inclusion criteria. And then you have to select studies or report for inclusion. That one too, selection of study, is also guided by some principles that we're going to look into. It has to assess the quality of each of the study or report included. Some systematic reviews don't do that, but it's really important when you're doing a systematic review to try and assess the quality of the studies included in the area of risk of bias in them. And you have to synthesize the individual studies and report them in an unbiased way, the same as the interpretation. So, systematic review may examine quantitative or qualitative evidence. So it means that we have a dichotomous binary systematic reviews that we do here or there. We have quantitative or qualitative, but now there are some of them which are emerging, and that is immediately you see the mixed methods are coming. So we have two forms of systematic review, the qualitative and quantitative. The qualitative normally is called the narrative synthesis, and we can talk about so many of them. Under that, we have realist synthesis, and that I think Dr. Milzoy would be able to tell us a lot about that later on. So many systematic reviews look at clinical effectiveness, but methods now exist to enable reviewers examine issues of appropriateness, feasibility, and meaningfulness. And you later on, when you move to, there's a slide over there that if 2000, somebody told you that you could do a systematic review on other things apart from a medical intervention treatment, you will laugh at that person, but now everything is possible. Systematic reviews are being conducted in every discipline. So now, why systematic review? Why do we even do systematic review? There's so many things that we can talk about, but I've narrowed this one to this, the practical one. Systematic reviews normally draw conclusions about, they really sum up the evidence level for us. So they draw conclusions about evidence, whether it is adequate or not, whether it's sufficient evidence to inform decision, whether to do new studies, a lot of things. It also, when studies reach different conclusions, it sort of address, systematic reviews address conflicting evidence and so many things. But one of the practical ones is that now over 3 million papers are published in over 40,000 biomedical journals each year as at 2007. So this is long ago, before the birth of these predatory journals. And you see that birth of the predatory journals, we have exponential growth of publication. And this is 2007. And the number has increased now exponentially. Many more studies never get published, especially most of the thesis that is supervised and most of the things, studies that students do never get published. They are all completed studies. To maintain current knowledge, a clinician or a researcher has to read about 40 articles a day. In those days, before the predatory journal. So because it's growing exponentially, maybe just double it. You have to read about 80 publications a day to keep yourself up to date. Let me ask you, how many of you are able to read an article a day, full article, even just 5 pages of an article a day? I think so few people are able to do that in a day, unless there's a need maybe to do literature to support your write-up, then you, at that moment, you will do. But this is something that you're saying every day if you want to keep yourself up to date. This is impossible for practitioners and decision makers to remain up to date. It's never possible. They can't. They're busy. The whole day is taken up by patient consultation. When they finish, they are tired. They have to write their patient report. How do they get the time to read 40 or 80 papers? It's really impossible. More so, when papers reach different conclusions about the same research topic. It's not surprising. If you go to the literature, the same topic that you are working on, someone else has done, someone else has, so many of them, some about 20. And sometimes if you want to bring everything on a common platform on the same table, we see that there are so diverse conclusions in reaching each of the studies. This is what makes systematic review essential, because it what attempts to collate, pull all the studies that have been published or not published, that have been conducted, and that have been maybe scattered, and I use the word, in a mighty ocean, that you try to locate all from different sources, the different sources, bring them together on a particular, on a table to be able to make sense of it. So systematic review is very important because it gives us the idea, the insight into the studies that have been conducted also in the area of our specialty. Then we come there, when you talk about this, we have, before the systematic review era, we had a traditional review. This one, somebody, an expert to be called, and then, or commission, do this one for it. We want evidence to support this. And this expert will go and gather all the studies that he or she has conducted. And most cases, just taking out the studies that have been conducted by others, which are conflicting their own reports or their own conclusions. So this one is neither normally. It's one or more authors, experts who do it. They are broad, specific, there's no study protocol, and a whole lot of things that made it unreliable. So we said that, okay, traditional reviews are not reliable, so now let us go for systematic review. And if you read this one, you know, you put everything, summarizes what I already said, but adds a little bit to it. So let's jump to this one and then go to qualitative versus quantitative. Then we talked about qualitative. The previous slide that I showed you also summarizes everything over here. So we have the qualitative and quantitative, and these are the reviews. And then let's move on to, some of them I'm jumping because when we start the main systematic reviews, we are going to take them one by one and go into details. Over here, I'm just highlighting some of them. We have the types of reviews, and now we can talk about more than maybe 14 of them. Just the reviews that you're talking about. So which one of the reviews are you doing? And is your review the best one that distills the evidence in the form that is really unbiased and reliable? We have a lot of clinical reviews, literature review, mapping reviews, but current nowadays, what has gained popularity is the rapid and scoping reviews. And especially with the advent of the COVID-19 pandemic, everybody, some even the journals, editorial basis will tell you that we are not going to do robust editorial or review. You just push through because most of them are scoping. Scoping is just to know what is in there. And the rapid review is when important question has to be answered in a timely manner, in a short time. You do rapid reviews. There's so many of them. But now, when you get to the evidence, the pyramid, I also mention something if I don't forget when I get there. So I just have to overview of reviews. But I think I'll be able to remind myself and talk about that. It's coming. Now we are moving ahead, going beyond even the systematic reviews that we are doing now. So at a point, you would ask me, now overview of reviews are coming. Why do we then spend time doing systematic reviews? You need to build a foundation before you put the rest of the blocks on. So we still need systematic review. Currently, it is the best form of evidence. So now let me take you back. I said, when I said systematic review, and the last bit of it, I said a systematic review may or may not include a meta-analysis. So this is, what is a meta-analysis then? This is just the statistical component or dimension of a systematic review. So we are saying systematic review has two dimensions that we can, or two forms. We can have the qualitative and the quantitative. All of them are systematic reviews because they are all going to use that methodical approach to synthesize the evidence. But when it comes to the level of analysis, that is why we have a dichotomy. That is when we come, the qualitative parts will just extract data, test as they are, and normally report them in tables, whilst the systematic review will use statistical methods to combine the data in a robust manner. And the synthesis too, we have different forms. We have the frequencies from way of pulling data, and we have the Bayesian way of pulling data. We will talk about them. And why is systematic review, meta-analysis important? By combining information from all relevant studies, meta-analysis can provide more precise estimates of effect of interventions done from the individual studies included in the review. So it's precision, and not only precision, it is robust. So when not to do a meta-analysis, when do we do meta-analysis, when not to do? So I'm starting with the first, when not to do meta-analysis. We have a slogan always say, garbage in, garbage out. Most people have heard it. What does it mean? It means that whatever you put, or the data that you have, it is that data which should lead to that systematic review evidence. So if you don't have good quality studies included in the review, you don't expect to get quality evidence from that. So that is garbage in, garbage out. When doing a meta-analysis, what do you have to? You have to identify comparisons. I will talk about this later on, but I want you to know the stages. When the things that you need to consider when you are doing a systematic review. In systematic review protocol, you consider all these things, the things that I'm talking about, to shape the review at the protocol level. Then why not traditional review? You've talked about that before, so I'm also just jumping in because of this. It's usually unscientific. And other things are coming over here, which we would consider later as we move on. So normally subjectivity is the most important thing because this is subjective. There's no transparency in that. I'm the expert and I say this, so I would choose whichever the studies that the type of studies I want to include. There's no opposition to that. And normally, because human beings are instinctively, we are a bit biased within us. We would normally introduce our bias into, even when we guard against that at a level, we introduce bias into our review. And that is why it is very important that in systematic review, things will be done independently by at least two reviewers. Independently, without knowing what the other person is doing, the same thing. And then you come back to the table and say, let us now sit down and see what you found and what I found. Where are we agreeing and where do we disagree? And then by looking at our disagreement and resolving them, we come to a common conclusion, and which is very important. And that is what we have started in the AMIX project. So those who are following the AMIX project, this one will be interesting for you to know. So the power of meta-analysis, why is it so powerful? We talk about meta-analysis. And for all you know, most scientists, those who are in the quantitative domain, if you write a paper and you just say meta-analysis, most people are not satisfied. They want to add the last component and meta-analysis. So why is meta-analysis so important? And why is that so many of them want to include meta-analysis? And it's important because often the benefit that can be expected of a new medical intervention or treatment is small to moderate, but can be important clinically. Let's move on. Usually, trials recruit too few patients or participants, making it difficult to detect such benefit. So when we recruit too few participants, that small to moderate beneficial effect, clinically beneficial effect will be lost through statistical analysis. So we have the statistical significance and then what the clinical significance. But normally we look through the statistical lens, and that's why most of us get it wrong. And that's why p-values at a point, when we come to that, we have to discourage the use of p-values and normally go for confidence interval, because confidence interval gives you at least the degree of the benefit enhanced. So meta-analysis improves the statistical power to detect such small to moderate benefits or effect of an intervention, because you have put so many studies together, and by so doing, you have increased the number of participants in the overall analysis. And that is, power is always determined by the sample size or the sample that you include. So let me use this one as an example why meta-analysis is very important. Before the advent of this meta-analysis, doctors would treat people who have cancer. This one is, I think, breast cancer, with either radiation, and that's the radiation alone, or radiation plus chemotherapy. But most of them were doing either of them. Why do we have to? Because each of them, you have to be strong to tolerate each of them. So why do we add radiation to chemo, whilst patients normally will not tolerate. So they will be doing radiation or chemo. But some clinicians sat down and said, no, we think that if we combine radiation and chemo, probably it will be better than radiation alone. And this one of the earliest systematic reviews that was done. And I'm using this one to showcase why most well-conducted studies will get it wrong. Not that the studies were not conducted well, but statistically, the studies were not powered to detect that clinically beneficial or significant effect. Look at all the studies over here. And I think most of you understand, if you know, later on when we're doing the actual quantitative, you interpret it. This is a forest plot. We are talking about the hazard ratio. The hazard ratio is used when we are doing survivor. We have the risk ratios and the odds ratios. You talk about all of them and the mean difference, you come to them. These are the measures, statistical measures that normally used to report treatment outcomes. So we are saying that if you give radiation plus chemo or chemo radiation alone, how long will it take a patient who has been diagnosed with cancer to live? That is so because the end point is death. So this is sensitive. This in the cancer area is sensitive, but this is, we don't have a choice but to use this example. Look at it overall. When you combine, this is the overall estimate. It is showing you that it is highly, highly statistically significant by, if not anything at all, we see the p-value with 0.00000 and those things. But if you look at here and look at this study, it's not statistically significant because it crosses one. We are looking at, this one is a relative measure. Hazard ratio is a relative measure. So when it crosses one, later you have the opportunity to discuss. This is a confidence interval. This is the estimate from that independent study, individual study. So all of them, except one study that said, no, radiation plus chemo is better than radiation alone. But let me tell you, if this study had not been, this systematic review had not been done, would you trust this study? It's a small study, And if you found all this, you found maybe 5 of them, all of them are saying, no, 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 there's no statistically significant difference between the two. Would you trust this small study? Just one. But at this point, this is the study that is telling us the truth. But I can say that probably this was just by chance. Looking at the sample size, it just probably, it got it right by chance. But after you have put everything together, this is the final estimate. Look at the confidence interval. This one from here to here. You can see the arrow over here. Long confidence interval, but this one is this, the edges of the diamond. That is so. The confidence interval is overlapping with the true effect, whatever it is. We will talk about the confidence interval and the sample estimate and how they work and when we get to the next stages when we're doing the analysis. So let's move on. And this is what shows that meta-analysis as a component of a systematic review is powerful because it is the only aspect that will be able to tell us whether a clinically beneficial effect has not been missed. If this were done in a qualitative study, it will have missed it because qualitative study will just summarize this, what they are saying over here, and pull everything together without combining it in a statistical manner. So it shows that the direction of this, almost everything is getting it wrong, so there's no difference. Everything is showing that there's no difference. That's what the qualitative analysis will tell us because we look at the graphicals or the estimate, and at the end of it, trying to make sense of it, giving us some margins of error. So meta-analysis is very important. I'm not saying those who are doing the qualitative synthesis is not good. Now, qualitative synthesis is gaining popularity, is gaining power. We will talk about that later because it will help us to answer so many questions that quantitative synthesis are unable to give us. And this also shows us that, don't go over there, the standardly sized studies addressing similar questions, most of them will be inconclusive because of our sample size. Most will have wide confidence interval, that's what I've talked about. And look at the table, expected difference. Normally, the treatment that we are comparing, the difference between existing treatment and then the new treatment is not 20%, no. Normally, most of them will be 5% or even 10%, except when you're probably comparing the placebo because placebo is nothing. So normally you get big difference. But normally, if an existing treatment and you want to come out with a new treatment, a clinical trialist over here will tell us. Normally, the difference is not that much. And look at the sample size you need to power your study. If the difference is 20%, you need just over 129 sample participants too. But this one is treatment, not the other studies, the questionnaire type. The questionnaire type, because of the degrees of variability, that one by intuitive, you have to really increase it beyond certain level to be able to attain a reliable evidence. If it is 15%, it moves straight away to 427. So it's not a straight line. When it gets to 10%, over here, it's 510. And then normally this is the difference. If you have to get about 2,030 participants. Let me ask you as scientists, how many of you are doing clinical studies that are recruiting 2,000 over 1,000 studies in clinical studies, looking at some treatment? Normally you have only few studies that participants that are included in our studies. So no matter how quality the study has been designed, we will miss that beneficial effect just by sample size alone because our sample size is not powered, study is not powered enough to detect that. So it is very important to have this in mind. That's why I always say systematic review is not just systematic review. Skills from systematic review is very important because it informs so many of the things that we do in primary studies. And I can tell you those who are well grounded in systematic review, when they are doing primary study, you can see the way they do their things because they are now transferring. Systematic review skills are transferable. They are transferring the systematic review skills, experience into or to inform their primary study.
Sorry,
if you can excuse me to just sip water.
While you have a small break, Tony, just do you want to enter the slide show mode, so people will have the full screen. I was trying to get in, but apologies.
Sorry. Yes. Is it better now? Thank you. So let's continue. Initially developed in the field of medicine, we are talking about systematic review. Now, systematic reviews have become a key feature in decision-making in many disciplines, almost all disciplines, including a few of them that I've listed, even in music. I remember when I organized a systematic review, a course for faculty members in the trainer one. Somebody came from the music, applied from the music department, and initially we took the person out because we thought that systematic review is not for music. Later on, the following time, another person, a different person applied from music, and we included, so let us take, because the person repeatedly was sending messages. And then when we came, the kind of the study design that he wants to use systematic review, I was overwhelmed. And I think it was one of the best innovative thinking that I have seen in systematic review. And I said, wow, I used my own bias to just restrict the person entry. But after the person joined, I saw that now you can do systematic review in every discipline. Because if you're unable to do quantitative, you can do qualitative, and then you can pull everything together. So these are the areas, even in crime, justice, immigration, everywhere, systematic reviews are used to inform decisions. These are the type of systematic reviews that mostly you can talk about, but I've talked about them, so let's move on. And this is something that I like, the pyramid of evidence. Why this pyramid and what information does it tell us? But everybody knows a pyramid. We have used in the demography to normally describe population structure and all those things and say, yes, if the base is this and the apex is that. But what does it tell us? So let me first of all take it that the base is broad. So it is what most of the things are accumulating at the base over here. So we have a lot in the base. And as it goes up, it shrinks so that we have only this few as you get to the apex. So it tells us that most studies that we engage in, that is cross-sectional studies, opinions, and other things are at the base of the pyramid. So in terms of evidence, they are the lowest form of evidence that we can find. But they, surprisingly, they form the major chunk of study designs or studies that we come across. So what does it tell us now? When we have moved on, I asked sometimes my students, I said, how many of you are doing case control study in a seminar, in a seminar of over 100, about 150? How many of you are doing case control studies? I got about 1 or 2. How many are doing cohort studies? None. How many are doing cross-sectional studies? Everybody's hand was up. You are all doing cross-sectional studies. And I said, well, it is not your fault because of the timelines that you have to do the study. You have only limited time. But almost the study design across low and middle income countries and even developed countries, most studies are cross-sectional and it's at the base of the pyramid over here. But I've told you that your systematic reviews, if your systematic review is the quality of systematic review is as the study that you have included. So if you include systematic cross-sectional studies in your systematic review, do you expect to get a very good systematic review reliable from it? Probably no. But a systematic review of cross-sectional studies is better than a single cross-sectional study when you want to use it for decision making. So as you go, now I'll take you quickly because I've drawn the base, and as you go, look at how it shrinks. Cohort studies are better than case control studies, but in some situations, case control studies will be the best study design to answer the question. Sometimes the cohort studies. But as you go here, the word that we have all known to be the gold standard evidence, the primary study gold standard evidence, randomized control trial, is now sitting in the middle. Now you see that there are some steps above it. And then from there you jump, and then systematic review is sitting at the apex. And look at it over here. It is the apex. But over here, the numbers are not many compared to this. So we don't expect to have so many systematic reviews. But these are the studies that are giving us the best evidence. But what I was talking about now, there's a new era that is moving from systematic review to overview of review. So now this overview of review, let me draw a line over here, will sit at the apex because it is tiny. Only few studies, this have just started, and they will produce the best evidence. But the unit of analysis will be a systematic review. While unit of analysis for a systematic review is a study, independent study. So let us move on. So we know from this pyramid that systematic review is the best that we can find. It produces the best form of evidence to inform our decisions and choices. And this is how we grade within the evidence. Other people, the SIGN, the Scottish Intercollegiate Guideline Network, has come out with this. I'm not going to go through how we grade the evidence. Normally, this is very important when you are doing guidelines, clinical or public health guidelines. So that is also a way of grading the level of evidence. But now, the level of evidence you talk about, that is not associated with the design, but how to grade the level of evidence. We have the grade, which has evolved and which is used to grade the level of it. This is not the type of study design we are talking about. When you have done your study, whether systematic review, you use the grade to guide you to assess the reliability of your evidence. So we will talk about them later as we move through the systematic review stages. So let us come to this. So now let's rest a bit and then let's move into a history. Now this is a storytelling. So how did it all begin? And an ARCHIE COCHRANE, an epidemiologist, published an influential book in 1972. This is blocking this one, it's 1972, on effectiveness and efficiency, in which he criticized the collective ignorance about the effect of healthcare. How did he criticize that? How can you, even one person, criticize the collective ignorance? And I will tell you that those people who have pioneered breakthroughs in science have come under serious criticism. Sometimes they are alone because their opinions are different. And I normally use the normal distribution as telling us that 95% will always agree and only few of them. We have the destructive and the negative normal distribution, and you have only few, 2.5 positive contributing to something. But those who are at the extreme and the outliers, the normality assumption means that they don't understand them. They call them abnormal. So when Cochrane started, and now forcefully talking about the collective ignorance, people didn't take it lightly. And they said, who are you to say that? He repeatedly said that, yes, it is surely a great criticism of our profession that we have not organized a critical summary by specialty or subspecialty, updated periodically of all relevant randomized controlled trials. He was talking about systematic review because at that time, people didn't have any idea about systematic reviewing. Then in 1987, he challenged them again. He don't look at the period between 1972 and 1987. He came again. In 1987, Cochrane referred to a systematic review. That is why systematic review has started, of corticosteroid treatment for preterm birth. That showed that a short, inexpensive course of corticosteroid treatment substantially reduced the risk of premature death due to complications. The evidence showed that had a systematic review been done or a meta-analysis had been done 10 years earlier, many premature deaths could have been prevented. But it wasn't there. So until after the systematic review was done, so many of them died unnecessarily. So this is, I'm showing a little bit of Cochrane, who is the pioneer of this, what we are talking about now, systematic reviewing. So this is when he gave the 1992 seminar, look at him, a young, curious guy. might not be that friendly, but sometimes you see intelligent, those who are so intelligent, they are always in their own corner. And then as he is growing, you see the humor that is coming because he has lived in the world for a long time. He has seen everything under the sun. So now look at the humor that you can see in his spectacles. And then the last days when before his death, this is when the transition that took place, and he contributed a lot. But let's see, did people appreciate him whilst when he was alive, when he was living? No. So I'm telling you, scientists, if you want this praise and other things, people have to tell you. I know some of you are maybe a senior than myself, but if you the junior ones that are coming and the mid-career one, please, if you let fame lead, you'll get it wrong. Please chase the right things, do the right things right, and fame will chase you. This Archie Cochran, when he was speaking all this, and he was not acknowledged. And the same thing happened with the Sackett. When Sackett started with evidence-based medicine, people ridiculed him. What are you saying? The medical autonomy. We medical personnel, we have to now give our autonomy out to patients, now to respect patient values. People didn't. But he insisted. The world is changing. If we do not change, it will be taken us by surprise. So please, let us change with the wavelength. And it took him, people did not understand him until latter parts when he was about to die. That is when he was acknowledged. And let's see, Cochrane was not acknowledged, but after his death, then some of the people that he wanted, the junior colleagues and some of them, the students, sat there and said, yes, we heard Archie Cochrane was telling us something. He was telling us something that if we had collated all evidence and put together, we could have answered so many critical questions. And it is an indictment on us not to have done that. So let us start something. Then in just 1993, a group of people came together to start this Cochrane collaboration based in Oxford. And this started from the pioneers in Oxford. And the person who championed the whole thing, say Ian Chalmers. Later on, I will talk a little bit about him. You will see him. Probably I won't talk about him, but I'll show a picture of him. But some of them are alive. Cochrane died not long ago. So what does it tell us? The Cochrane collaboration is an international network of researchers, academics, practitioners, and users committed to the principles and management of healthcare knowledge and all those things. They are just selfless people who don't charge for what they do. They just contributors, and they are producing evidence to support decisions across every discipline in the world. And it's a powerful institution now. The last time I counted, there's so many, the register is about, when I get there, it has expanded to thousands of researchers, practitioners now doing Cochrane review. So over here, what I wanted to say before this is that the systematic review that we are talking about, if you don't know anything about systematic review, please don't be worried at all. Don't worry. It has started no long ago. So I'm happy that even Taleb, when he was introducing me, talked about my 1996. Yes, at 1936, as a junior scientist who has started, and I said I was going to do a systematic review, but the paper, I will send it later for you to read and see. It took 7 years to publish that paper, but it has solved a big problem. We'll talk about that. So I did not follow any formal course, but I started that we have to find an innovative way of answering. And that paper, I'll send it to you, how the critical issue that was at stake to answer. And that's what gave me the opportunity to get myself involved in systematic review. But my journey has been a long one, moving here and there. So I have not been on a straight path. So yes, I did systematic review long ago, but I actively resurrected in the 2020s after around the 2004 again. And since then, I have not backtracked. So that is it. So systematic review started not long ago. So please, don't worry. If you are now hearing or you're starting, you can make up what has been, or you can make up. That's what I want to say. This is the 20th anniversary of the Cochrane collaboration. But now Cochrane collaboration has changed Cochrane. So it's no more collaboration, just Cochrane. This was done in South Africa, Cape Town, And I think I was there, and I had a chat with some of the, Sir Ian Chalmers. He's the person who was the Oxford. And then this is a renowned professor in South Africa, Amy Vorming, who is was the director for the South African Cochrane, the Cochrane Center, but he's also the dean of the University of Stellenbosch. They've done a lot of systematic reviews and evidence-based approaches over there. He trained in Oxford, so this Ian Chalmers knew him. So when he was going to South Africa, he said, okay, if you are going there, now we have set up the Cochrane collaboration. Why don't we now set something in South Africa? So South Africa Cochrane Center is one of the first. I think it was set up in 1996, just soon after the Oxford Cochrane, the UK Center, which was the first, before others came to join. And the 1993 to 2013, it was a landmark, the 20th anniversary. So this is, Cochrane had just attained only 20 years. So it's not long ago. And when they cut the cake, I was there just watching with admiration and then saw how it went on. And then over there, this is some information about the Cochrane collaboration I've listed over here. I'm not going to talk about. Then within the 20th anniversary over here, after that, the Cochrane committee met. And this one, you can't go and pay, you can only go and pay your eyes over there, but you can't get in over there. Because you see, these are the think tanks of the Cochrane collaboration. They are making the decision over here. And you see, say, Ian Chalmers over here, and other think tanks in the evidence. We have a lot of people that can't mention names. There are a lot of think tanks over there. And they decided making decisions for the next year Cochrane. So this is the steering committee over there. And if you try, probably one day you become a member. Normally they advertise, and if you qualify, you apply, and they will nominate it. So you can apply and become a member. So moving beyond, Cochrane collaboration started at the first entity doing systematic reviews. And it started in the area of medicine. And that is why evidence-based medicine could be coined immediately. But after some time, we have other network coming up, and this was the CAMPBELL collaboration. Also, it is a sibling of the Cochrane collaboration, but DS adapted Cochrane methodology, but they are more interested in criminal justice, poverty. These are complex issues. So if you're doing something like that, the best way to, the best network to link up with will be the CAMPBELL, or you can also link up with the 3IE. They do almost the same thing. Then another one said, okay, we AP reviewers say, okay, education is very important, but normally the methods and other things are not really evidence-based. So we would spend our time doing evidence-based approaches in the education and how we teach, how we deliver education. And that is how they do education. But the methods are also just the same, the adapted form of the Cochrane methods that are used across board. And I list a few of the institutions in the UK. And let me point this one out. All this has been championed by UK institutions. UK has done a lot in evidence-based in Oxford, and that is, everybody knows it. So I just listed a few of them in the UK. A lot of centers in the UK that are involved in evidence-based approaches. And then I decided to bring this over here. This is the village excellence. And I hope some of you have come from York, and the York people who are here, probably you are sitting in one of the rooms over here, over there. This is the York University. And then I'll show you the Center for Reviews and Dissemination, which is situated in the York University and which does a lot of work, evidence synthesis. So I talked about Cochrane, so I decided to also talk about the CLD. And then NICE, I had a slide about NICE after the evidence has been synthesized. Then the next level is translation, translating the evidence into algorithms, that protocols, algorithms that can be used in the NHS. That is done by NICE, and NICE has collaborating centers working with them. So this is what is happening. So CLD has done a lot of work, and I worked over there sometimes, so I use the credit. And let me acknowledge this fact that the slides, some of the slides, some of them would have borrowed from a Cochrane learning resource, and some of them from the CRD resource, and even some Campbell and other epi info, wherever I found something good. So this is a blend of resources from so many places. So let's go about it. In the early 2000s, if one spoke at public health conferences or seminars about the need for systematic reviews, many of them would laugh at that person because they thought it was not possible. However, the climate has changed considerably in recent years, and it is widely accepted that much research is unreliable or simply not relevant. That systematic reviews can be used to, as a useful guide to the evidence and the gaps in evidence. What is it telling us? That much of the primary research that we do is unreliable, and that matter whichever area that you are, try and make an attempt to pool, to synthesize the independent primary studies in the area, in that specialty, to answer the question. So now, even public health, 2000, nobody would think of doing a public health systematic review. Everything was treatment A versus treatment B, intervention. When you talk about intervention, you're talking about actual treatment, surgical intervention, and then therapeutic interventions. But now, the paradigm has shifted, and everywhere, as I show you, systematic reviews can be conducted. These are the lists of the UK. The SHA is also there, Penn Clark. So many of them are also here. I listed them just to sometime introduce some variety. Now, systematic reviews that have directly informed policies for clinical practice. One of them that I use is that this magnesium sulfate was considered ineffective by experts for eclampsia. And most of the clinicians, you know, the eclampsia, we are not going to talk about it, but a serious condition. And then the drug of choice in Europe was phenytoin. Only mention of max sulfate was somewhere by some obstetricians in North America. No mention anywhere else. So it was not used in Europe. Then a study was conducted, a multi-center study, which is like they used a prospective like systematic review because they had in mind to combine the study. It's not real systematic review, but we would term it that way because it was done for that purpose. They conducted the systematic review of magnesium sulfate versus phenytoin. Look at it for 775 women from South Africa and India. And then the main symptom, the main presentation, repeat convulsion and maternal death, the outcomes. Look at max sulfate. 22 of them out of 383 experienced repeat convulsion, as against phenytoin. Phenytoin is 66, but this is the drug of choice in Europe. And then if you look at maternal death, look at in magnesium sulfate, it decreased maternal death, but over here, it's about twice maternal death in phenytoin as compared to the magnesium sulfate. But all along, clinicians in Europe and the obstetricians and all those were using phenytoin. But this study, after the publication of this study, changed the evidence. If you look at the confidence interval, this one is statistically significant. They are not, p-values are not here. So at a point, I say we will win ourselves from the statistical significance. This one is not statistically significant, but probably we'll talk about that. But it shows that in terms of presentation, clinical outcomes, phenytoin performed less than you have in magnesium sulfate. And this is the drug of this one that I was talking about, interpreting low proscontal cure rate. I'm now delivering this also. I decided that this is individual's own biases. So allow me to introduce this bias over here for a purpose. This was what I was talking about. We asked this one for proscontal because proscontal happened to be the only drug used in the treatment for schistosomiasis. There was no alternative. In the early 1980s, every drug had been moved from the WHO essential list because praziquantel, which was broad-based, effective, with less life effect, had been introduced. And a few years after the introduction of praziquantel, which had worked very well in all settings, then a treatment outcome showed about 32% of treatment outcome, that's cure rate after treatment of praziquantel, which was serious. So the question was that resistance was emerging against this drug, but there was no quantitative evidence to support that one. And that's just what led to, and it carried on from the early 1990s to the late 1990s. People repeated, all studies that they conducted around the area, Senegal, showed that the cure rate was far, far, far lower than it would be expected for praziquantel. So we put this one together, and it took about 7 years. We started presenting this one in conferences around 1997, 1998, or so many conferences before it finally came out. But one thing is that it had an authoritative conclusion that resistance had not emerged against praziquantel. And it detailed all the reasons why. And we're able to quantify. This one is a Bayesian systematic review. You have the frequencies and you have that one to show that there was no resistance. And that is what led to the first mega donation in these neglected tropical diseases by the SIC, the Schistosomiasis Control Initiative, supported by Bill Gates, which was based in Imperial College, to get the biggest financial support to control schistosomiasis, doing mass drug administration. Why? The drug that they thought that resistance had emerged against, and people were thinking that we were going to discard it, after the conclusions showed that no, there was no resistance, so you can use even in mass quantities. And now they have treated millions of people across endemic countries, especially in Africa and in Asia and in Latin America. And since the time that we said there was no resistance, up to 2020, there's no resistance. So that is what I'm saying, that sometimes the systematic review, it takes time. If you want to produce the best form, it takes time. If you're in a hurry to publish, to add to your publication list, probably don't do systematic review, well-conducted systematic review. It may take a lot of time. But if you are thinking about the end product, helping impact life, helping to shape policies, then no matter how long it takes, you have to work on it until you come with the answers. It's not that straightforward. So this is one of it that showed the systematic reviews that impact policies. We have the one for amodiaquine, which was also done by another group, COCHRANE group. Amodiaquine was discarded, but later on, after the systematic reviews, it was brought back into use again. And systematic reviews have informed so many decisions and policies. In the developed world, no decision is made or policy is made without systematically synthesizing the evidence. So now, that is what, but in low and middle income countries, probably that is not the order. So that is why this seminar or this webinar is critical. Let's look at those. Most of us are all researchers, reducing waste through evidence-based research. Now there's a school which is coming, evidence-based research, which I'm involved, and this is what we are doing for this, the cost action, trying to see how we can minimize redundant research, and now using systematic review evidence. So if you see the title that I give, I said evidence-informed research. How can we do evidence-informed research? That is what evidence-based research is. You need to be part of what we're going to discuss later on. But I'm using this one to say that research which duplicates other work unnecessarily or which is not of sufficient quality to contribute something useful to existing knowledge in itself is unethical. This was done by the UK Department of Health, 2001. So if you just duplicate and you just do research, it's unethical. That is why the title, let's say, demand-driven. Your topic should be what? Innovative one. And it should be evidence-informed. It should be demand-driven. It should be also what? Policy relevant. And it should be contextualized. Why should the context come in? There are so many studies that low and middle income countries have imported into their setting to use, which didn't work because context is different, situation is different. A lot of things, epidemiological situations are different. So a low and middle income country, to do the right research or the systematic review, you have to do systematic reviewing in context, so contextualize systematic review. And over here, strikingly say, 85 to 90% of research is waste. Why would they say that? This one is published in Lancet, 2009. And it leads to waste of about 85 billion. That was us at 2009. So look at the amount of money that is wasted on redundant research that does not contribute anything. And that is what we are having all around. People are just publishing. Sometimes if you ask them some of their own topic studies that they have done, they won't remember. I can tell you some of them will not remember their own topic titles. But that is good because that is the currency. But we are saying that before you do a study, even if you do one, and you observe all the quality checklists, and then it helps inform decisions and policies, is far, far better than doing so many studies, which do not help. So this 85 to 90, where would you place your own research? So now we are talking about 85 to 90. So we have about 15% on the upper margin. But if you come to the lower margin, it's 10%. So all these publications that we are finding, millions of publications a year, so only 10% of them can be considered as good. And we end up losing billions of dollars. It is simple. So it is essential that existing sources of evidence, especially systematic reviews, are considered carefully prior to undertaking primary research. That is what that evidence-based research is telling us, on the basis that we are wasting resources and then we are also producing unethical research because they are duplicating. But let's talk about some of the practicalities of systematic review. It can be time consuming. I've just listed a few of them. This one you can all imagine when we start doing it. You will list them each stage that we get to. We are going to list all the practicalities, the problems that we have encountered, and what the kind of thing, everything we are going to document. And that's when we get a feel of this. But we know that it can be time consuming, especially if you send it to the Cochrane database, because your protocol has to be published independently from the full review. It has to go through peer review. And sometimes Cochrane reviews, the one I did, normally the average number of years it took was about 3 years, more than that. I remember one of them took over 4 years. So, and you are waiting for that one paper to be published. And if you want to get this paper for publication, look at 4 years, you still be marking time and it hasn't come. So that is kind of things that we have to consider, some of them, but it's robust. So if you publish it there, you are sure that I have published a good piece of paperwork. It's important. BMJ2 normally also publish their protocols. The advantage is that sometimes other people are looking, and if they find something like that, they are fast. They replicate that one and publish in another journal. By the time you realize it has been published. So now there's a school of thought. People are thinking about it, whether it's the best idea, but still it is the best idea. So there are so many things. So now let me talk about this one. The evidence synthesis situation in low and middle income countries. And I guess most of our participants over here come from low and middle income countries or living in low and middle income countries and working in low and middle income countries, even those from Europe. So they know the situation, they understand the issues that we are talking about. Let me do some presentation for you over here to see the capacity of evidence synthesis systematic review in low and middle income countries. Before I show you the graphs, we know that although systematic reviews generate the best into bracket overall evidence needed to inform sound decisions and policies. And in developed countries, the highest level of evidence used to inform decisions and policies about what works and what doesn't work, even new research, comes from systematically synthesized evidence from systematic review. This is not the case in developing or low and middle income countries. But now the paradigm is shifting, and decision makers in low and middle income countries are increasingly looking for quality evidence to inform their decisions. And if you follow WHO critically, one of the things WHO is channeling is implementation research. Why implementation research? Because almost everything that is implemented in low and middle income countries doesn't appear to work. Why? So WHO has set up the implementation research agenda to understand the issues, why policies don't work in this context. The capacity to undertake, though they require now increasingly, they are looking for evidence to inform their decisions, but the capacity to undertake systematic review or do evidence-based research is less well developed. And let me add something, maybe short story over here. When I moved to Ghana and I started this, at the PhD level, I had a regional director in the class, and I had two of them. And then we asked, how many of you know something about systematic review? These are the top policymakers. And then it appears nobody had any idea about systematic review. And during a seminar of the same, about 150 students, I asked the same thing, like the first question I asked, write it on a page of paper, what is systematic review? I gave them about 5 minutes, and I collected all the papers. And then normally, if not because of this is a webinar, that's what you were going to do, so that we can use that one to assess the level of the participants over here, so that we know how to build on or how to guide. But because it is a webinar, we won't, and because of time, we can't do that. And it will surprise you that a lot of people did not have any idea about systematic review. So then that is when I started that instead of now doing publication, let them start work and develop curriculum to now sensitize people. So all the things that I've done have been sensitization. It was lately that I started now doing the full systematic review to now build the capacity, train the trainer and other areas. So those who are coming from other places in Africa and Asia, you would agree with me that this is new in most of the areas. When we're talking about evidence, people will just look at any primary study, take any primary study that they know and have been published, use the evidence to inform their decision. But that study might mislead. So that is why it is important to now collate, bring every study that has been conducted out there on the same platform and assess quality, combine, and now come out with the estimate or what it is telling, make sense of it and use it. So this is where less well developed in developing countries and low and middle income countries. Let's see. Now this is I hope you see this one, because this one is blocking the C waiting room. Can you see the title over here? Admit and shall we? I think somebody is there and blocking the title. Can you see the title? Okay, then from your end you can see it. So probably I can admit and then they are moving. So these are the number of review authors from low and middle income countries in the Cochrane collaboration. I said, systematic review started as a Cochrane collaboration. So anybody who has interest in doing a systematic review has to go through the Cochrane channel. Although nowadays there are so many networks that are doing systematic review, so you don't have to go through Cochrane. But almost all the networks are sister networks of the Cochrane. So most of the leaders in the networks that we are talking about are also part of the Cochrane network. So you'll find, if you want to find information about their sister network, you get all the information also in the Cochrane database. So let us look at the first one that was presented. Now, with more than 100 review authors registered, that all those who have participated, not the first authors, but who have participated in systematic review, Cochrane review. Look at China, we have 2,264. These are absolute numbers. So now translate that numbers over the population. You can see this one will be infinitesimally small because of the China is about something 2 billion. So if 2,000 people are just so, it is just like a drop in the ocean. You won't even find them. And then if you come to Brazil, Brazil is also almost like a continent. Look at 750. They are doing well. They're 750. And if we come to India, look at the population, 440. Let me jump that one onto what will be interesting. So if you have more than from 100 or more, but the absolute numbers over are here. So Argentina has 104, Chile, and they are doing good. Let's go to the next one. They say we are looking for authors, countries with 11 to 100 review authors. What are we saying? From this one, we see that let us please, check whether you can find where your country, where they are faring on this one. So we have Nigeria. Nigeria is doing very well. Nigeria, we have 94 over here, very good. Because Nigeria too has the COCHRANE branch over there. And COCHRANE network, you have to register. Anybody that comes to or has to do systematic review has to register. So they've registered a lot of people. And you also find South Africa because South Africa has the COCHRANE Center and is registering people. So Nigeria and South Africa are doing well in the African context. But even Nigeria, look at the population is, the last time I knew it's about 150. Moji and Temi, I think it's about what is the population from Nigeria? If you haven't, you can unmute and tell us what is the population in Nigeria. Is it 180 million? Is Temi and Moji around? Are you with us here, or you've left? Okay, let's move on. So let's look at over here, Peru and Kenya.
Yes. 290.
Yeah. What is the population of Nigeria?
200 million, I think Temi has just texted through the chat.
Oh, okay, good. You can see, so only 93 of them. So if you distribute them, look at where you find this one. So it's just too small to produce the decision support papers that Nigeria will require. Let's look at, do you see any sub-Saharan Africa? I want to look at the Asian group, Vietnam, if I can find over here, but no, I haven't found Vietnam. And I can also find Ghana. Hey, so what are we doing? There's no Ghana. So we don't have 10 to not even 11 over there. So now let us move, probably this one will give us the opportunity to find the number of systematic review for this. So anything less than 10. So the maximum is 10 individuals registered on the COCHRANE database. So we look at it, you have Jamaica, Cuba, Tanzania is here, Malawi, Ghana is here. Now you have Ghana, how many of them? 8. Let's go down. If you find most of the rest of the African countries that are at Zimbabwe too. But over here, look at it, I found Vietnam over here, 4 systematic reviewers in the whole country. So now let us rest our case over here. What does it tell us over here now? It means that now the capacity to produce the evidence required for policies and practice is less well developed in these countries. So now it is incumbent on you and I to start something now to build capacity. All of us to work together as we are doing now. So I'm grateful to Tole for allowing this on the platform. He's the PI of the studies and allowing me to speak. I thank also Professor Japan for Irene Japan for inviting me. I was there and he just invited me, Tony, there's a program, I want you to join. I said, okay. And he brought me onto the two projects. I'm grateful because it is this project that have given me the platform for me also to share the ideas I come. Otherwise, people will not have known me, except those who are in the synthesis business, a few of them. But even if I'm not in that specialty, you won't find me. So I'm grateful. But now I'm throwing the challenge to you. Are you prepared to join us to work together and to now do innovative, evidence-driven, demand-driven, policy-relevant, contextualized reviews to support evidence to strengthen our health systems and improve patient outcomes in our setting. So I hope if you look at these statistics, and one thing you know that from economic point of view, economist point of view.
Catch flight home. Well, hopefully next week. Okay. The week of July 1st. Yeah.
Sorry, if somebody's mic is open, so are you talking to us, or if not, please mute your.
Yeah, apologies for that. Please carry on, Tony.
Okay, sorry about that. Sorry about that. So it's a challenge to all of us now. After we leave here, are we going to come and sit down, listen to webinar and go? If I will, let us start something. That's why we are doing the project. So this seminar, I will talk about after I finish this seminar, how the next stage is, what we are going to do. So by the time we finish the webinar series, everybody will have a full systematic review, which he or she is working on, maybe in groups to work on, so that we can use this one as a learning curve and as a guide. And by the time we finish, at least we can produce systematic review. Without that, then I'm giving you a take-home message now. This is something I borrowed. Then later on, I was looking for the source where I got it, but I can't find it, so forgive me. That's why I'm using quotes. It's something I like, and I'm continuing to use it, but I'll look for where I found this one. The question has moved beyond what is systematic review. Why systematic? The question has moved beyond why systematic review is important to why is it not already a reality in most low and middle income countries? And how can we all work together to make it a reality and quickly? So it's no longer a question that is a systematic review important? Is it useful? No, we've passed that stage. If you ask that question, nobody will answer you because we've passed that stage. So the next question is, why is it not a reality in our setting in low and middle income countries? Why has it taken so long? Because this is not something like the innovative ideas like maybe building an aircraft or something that because of our maybe infrastructure and maybe money will not. But this is something that is of low cost. Why is it not a reality in most low and middle income countries? This is a challenge. And then now the challenge is that how can we all, it's a collaborative, systematic review is always not one person enterprise, it's multidisciplinary. How can you all come together to work together and now make it a reality, and not just a reality, quickly, because now people need evidence. Now look at the COVID-19. There are so many things I listed. One of them is the capacity and preparedness of African health systems to support COVID-19. This is very innovative, but I started it, but I haven't done it because I will do it alone. But if you have so many people and then we come together, this person doing this person doing something, we can come out with something fast and then inform evidence. So we need you. We need you on board. This is a plea. Everyone have pleaded with the people, but even when I pleaded the most, nobody is coming on board. But the good news is that in Ghana, the last time the South African Evidence Synthesis Network compiled the new capacity in evidence synthesis, Ghana was the second after South Africa. Ghana is doing well, a lot of them. And I trusted the analysis because when they move further, have you heard about systematic review? Have you been involved? Yes. But they say, have you produced or published a systematic review? Almost all of them no. And it is true because it started not long ago. We started the sensitization and the work not long ago. So if people were saying I have produced systematic reviews, whilst I know it will have been something misleading evidence. But because they said, no, we haven't produced, I accepted the evidence as credible. Ghana is doing very well because we are hammering systematic review. The rest of the countries, I don't know, but I think systematic review is less well developed. So I urge you, all of you, to join the movement. Thank you. So back to you, Tolib. I've finished with my presentation for the day.
Okay, fantastic. Thank you very much, Tony. That's really helpful. I can see the virtual clubs coming through. Do you want to stop sharing your screen so we can see colleagues?
Okay.
Yeah. So it should be on the top, yes.
Okay.
Brilliant. So lots of clubs coming through, that's good. And also thanks coming through the chat. So that's good. Well done. So excellent. So, and we stuck broadly to time, which is great. And that means we have got a bit of time to engage in the conversation. And we'll have an opportunity to answer any arising queries and questions. That's been a really useful introduction, kind of overview of the history, overview of the rationale and importance of the systematic reviews, as well as the kind of key issues to consider in the systematic reviews. So let me pause at this point, maybe open it up for any questions, comments. Colleagues, please, if possible, either raise hands, and I try to keep an eye on raised hands, or indeed drop the questions through the chat and I'll try to pick them up. So can't see any hands raised yet. I think, Augustina, there is a sign, go faster. I'm not sure what that means. Is that me need to go faster or?
No, no.
Okay, okay. I've been told by my children that I am slow, so that's fine. That's no offense taken. Okay. So Amma had a question about why systematic review takes so long. I think that's the first question from Irene. Tony, do you want to take this question whilst colleagues are getting their heads around maybe further questions? So the question is, why systematic reviews take so long? What is the main reason and rationale?
Yeah. So if I should answer, who asked this question, please?
It is Irene on behalf of Amma.
Yes, I did as well.
Okay, okay. So the simple answer is that not all systematic reviews take that long. It depends on the path you choose. And that is why some of them go through the protocols being published before you can do the full systematic review. Some of them also, you just write in your systematic review, and when you have finished, you send it to any journal that you want to publish in, and you just submit it as any other manuscript. So that one, you are not regulated. You just do it and send it. But from my experience, if you are answering a pertinent question, because what your systematic review has, the questions that systematic reviews have to answer are the questions that remain, the gaps in knowledge and science and practice that you want to bridge. So they are not simple questions that, if they are simple questions, somebody would have already answered it. So I always say that to be a part of the discussion table and making your systematic review speak is to go that way. Do the systematic review. That takes time. That is difficult to do. And that is only when you contribute to the discussion. But if you take that path, it goes a long way, because sometimes it depends on the number of studies that you would retrieve. You do a search strategy and you search all relevant databases. Searching sometimes you have the information specialists who will help you. Sometimes you do it alone. When we get to the search, you take all these things into consideration. And then depending on the number, let me use an example. One study that I was doing with a group that I will mention the name. initial search retrieved about 75,000. After everything had been done to improve on the sensitivity and specificity, we got about 35,000. So 35,000, you have to go through all of them. It takes time to go through 35,000 abstracts. And after, assuming that you get so many studies that are potentially eligible to be included, you also spend a lot of time to go through all of them one by one, the full test, to now extract the information. It takes time. But it's a matter of the number of studies that you're going to include and the methods pathway that you have chosen. If you want to go the rigorous and the robust way, normally it takes time because you have to wait for the other independent person to come so that you discuss and agree before you move on. So there will be one rate determining step. The slower person will always determine the rate. One person, if you are moving fast, you will be put in check by the one who is the slower, who is not that fast. So this is what makes systematic review a bit time consuming and it takes time. So not all of them. The rapid reviews can produce a rapid reviews in 2 months, 3 months. And then when CRD, Center for Reviews and Dissemination, another place, we call something the single technology. That you are only looking at one treatment or one intervention. And then when policymakers need this one, they need evidence to inform decision. You call rapid review. Do it fast. You go through this robust measures processes, but it's something that you do it fast, and you can get a systematic review done by 3 months, 6 months. But mostly, if you go the COCHRANE way, the BMJ way, and those that we all respect, that is what takes time. And I've told you already that we have about 80 to 90% of the studies that are that doctors are not good. They waste money and they waste time. So only 10 to 15% of the studies are of good quality. So those who are right, some people may produce, but COCHRANE is trusted evidence. And so that's why I use that one for you to gauge. Because I'm involved in some WHO guideline. The question they gave me to answer, it has taken me over 3 years now. They thought it would take us less than 1 year. I told them beforehand that this would take a lot of time because it's complex. And they themselves have got to know that it's complex. So it depends on the topic that you are working on. If it's just A versus B and it's straightforward, you can finish up within 6 months or 1 year.
Okay.
Have I answered your question?
Yes, thank you very much. But I will just type in others and you can get back to me at any time. Thank you so much, Doc.
Okay, thank you.
Oh, fantastic. Thank you, Ama, and thank you, Tony. There is quite a number of questions kind of coming in quite nicely. And I think you've started touching upon some of those in terms of the length and the kind of the overall number of records on the systematic review. I was wondering, Tony, whether you would be able to briefly kind of remind colleagues of the key steps in the systematic review. So so starting with screening, first the searches, then the screening, then the quality appraisal, and so on. And maybe that will help answer some of the further questions. And then I will keep an eye on the questions that have been typed up, and then hopefully we will engage in further questions. Would that be acceptable, Tony?
Yes, to show my screen again.
No, just remind briefly. Well, if you want to show the screen, but if
about the steps of doing systematic review.
That's correct. Steps in the process of the systematic review.
Let me go back to the slide that defines systematic review. Go back fast and no, I can't. Sorry about that.
It's a very rich presentation, so
yeah,
so it takes time to come through.
Yes,
it's fine.
So this one is this is the definition. So let me highlight here. This is the part. If I'm able to highlight, and let me move it to this mode. It has gone back, but it uses, these are the stages. First of all, you have to formulate your question. So a systematic review is not like any other study. Sometimes people decide to do a study without having a clear question. They come out with objective. But systematic review, you have to have a clear question to answer. If you don't have a question, don't do systematic review. So we start with that. And how can you now come with clear question? We call it formulating your question. We will do that when we start the protocol. We use the PICOs. I haven't mentioned the PICOs, which is one of the important ones that we're going to, which describes the population or the patients, the intervention, the comparator, the outcome, and the study design. The PICOs is very important. So you use the PICOs to now define your population succinctly so that they know exactly. You now use that one to now purge that these are my bounds. Beyond this, I'm not considering. I'm considering this. So I'm interested in pregnant women, age between this and that, who have had this, who were treated in this one. This is something how we do it. And from there, after formulating your question, then you have to comprehensively search. This is identify the studies. You only identify studies by searching. And so all the studies are scattered on the electronic databases. Some of them are non-electronic sources. You will talk about them later on. So you have to identify relevant databases to be able to retrieve the studies that you are working on to answer the question. And that one is the databases, you will talk about them. But you have to now develop the search strategy. It's a strategy. It's not like doing literature review. You have to build your search strategy. And after you have done the search strategy, we have the Boolean logic and operators to now search. So these are the steps that you go through. Formulate your title or the question. Now do a comprehensive search or build a comprehensive search strategy and search. After you have searched, then you have retrieved so many studies. You have to select studies. So the next stage is selecting studies. And you will talk about what we need to do when we selecting studies. There are so many principles and guidance that we do and how we do it. After that, we would have to critically appraise the quality of the studies that you are including. Other people extract the data before appraising, but most people would appraise the study before extracting the data. Anyway, however you do it, it's no problem. So that one, we have some guidance or the tools that we use, the risk of bias, COCHRANE risk of bias, and then so many tools that we can use, and then why some tools should be discouraged. You'll talk about them when you get to this level. So that one, you assess on some 7 main domains for clinical trials. If you're doing cohort study, case control studies, we have validated tools that you can use to critically appraise or assess quality of the included studies. So after you have assessed quality of the studies included, then you extract the data, and then you use also validated and piloted forms to do that. And then after that, you analyze. So formulate, search, select, assess quality, extract data, analyze data, report it in a form that is accessible, not just report it in where, because you want the evidence to be utilized. Report it in a form which is accessible to people, and interpret it. The last one will be because it is like it's a publication. So go through all the IMRAD that we are talking about, the introduction, the methods, and all those things. It's a research methods. So these are the main stages, and you don't jump any of the stages. But within each of the stages, there are specific details in them when you get to the methods, selecting, and then all those things, even the analysis. There are specific details that if you are not careful and you don't do it well, you compromise the quality of the study. So these are basically the standard steps that you would need to do a systematic review.
That's brilliant. Thank you very much, Tony. That's really helpful. And I think it touches on various questions that have come through. So one group of questions that actually relates to this relates to the scale and the timing of the systematic reviews. So there was a question, is there ideal time in years in the systematic review? So related question was, how many papers can you physically kind of able to read in a day when conducting a systematic
Yeah.
review? And then on the scale, I think the final question came in was, what's the minimum number of papers needed for a systematic review? For example, if you are getting only 5, 6 papers on the topic of interest, is that enough? So do you want to touch upon the scale and the kind of the timing, and then I will throw some further questions about the quality that have come through.
Okay. So getting to the practicalities, you know, the one I said you have to read about 40 papers a day is person who wants to use the evidence to inform his or her decision, not necessarily somebody who is doing a systematic review. But if you are doing a systematic review, selecting the papers might be slow. It depends on the topic that you are doing. Some topics are so complex, they are not straightforward. So you have to always visit your checklist over and over, even when you have done a couple of them. So it slows you down. But the number of studies that you need to do a systematic review is, we don't have any number of studies, because systematic review is made up of full, how do you call it? Is a priori, something that we do. We design the study before we got to know what is there. So my aim is now to find evidence on A versus B. I don't know what is there. So that is all that I go. So if I search and I get one study, that is all I have. It is still a systematic review, because it's the process that is important. It is the meta-analysis, the statistical component, that you would require more than one to be able to do a meta-analysis. You can't meta-analyze one study. The reason is that the one study is just one study, so report assets, because after all, that is what the authors have reported in their study. So use it and report assets. But if you have more than 1, 2, you can do a meta-analysis. 3, you can do a meta-analysis. 4. So sometimes 2 papers, and when you do working on 2 papers, it's fast. Within a short time, you are finished. You can finish your systematic review. But if it comes to the hundreds, sometimes you'll find about 400 studies meeting the inclusion criteria. These are the studies that you want to analyze. It can take a lot of time. And so systematic review and also the number of studies will determine the kind of statistical approach you use. If you use the forest plot, you see the one I'll show you, treatment A versus this, at a point, you can't continue, because if you have 400, it is so long. How can you report it in that way? Probably you can't. So you have to find maybe another way of reporting, maybe some innovative way of reporting your data, which will not be the forest plot, maybe having 10 studies with the confidence interval. So it's a whole lot of things. But the other one is the practicality, the timing. It depends on you and the resource you have at hand. If you have experts doing the search for you, then that one experts has taken care of. The person will contribute to probably writing the search strategy part, and therefore that one saves time. And then if you have a lot of people, you can share the responsibilities. But the question is that we always have to make sure that we do the same thing, we agree. And we know by intuition that whenever the number of people increases, then the disagreement also widens up. So that is when the kappa score becomes something narrow. So that's why we have to guard against that. So many people will take bits and pieces and then now join together. That one is not a good systematic review. A good systematic review is that where 2 or 3 people have committed themselves to it and independently assess whichever stage, extraction, selection, and then coming together to reach consensus and moving on. So I think have I answered your question?
Well, those were questions from different colleagues.
Okay.
So it's, I think you touched upon how many papers can you absorb physically in a day, and is there any ideal kind of timing in
That
years?
one, let me get it before we move on. You can't determine that. It will be determined by the nature of the study you are doing. Yes, so sometimes you can extract only 1 paper a day. Some of them are difficult because sometimes you have to go over and over again so many times before you Yeah, over and over. But sometimes if it's so simple, you can even do 10 studies a day. But normally you can't do more than 10 studies a day based on my experience, even if it is simple studies, because you have to read the study from the abstract to the end, including the discussion. And sometimes after you go to the discussion, you come back and see that there's something in the table that you need, you haven't seen, and you have to sometimes read it all over again to spot it. Because sometimes it is hidden somewhere. And it's sometimes you can read it over sometimes 5, 10 times before you put it aside. So that one depends on the pressure on you. And that is where so many people muddle up. They just succumb to the pressure and then just do anything and then don't really be robust in that sense, meticulous. But if you are being meticulous, it takes time.
Yeah, that makes a lot of sense. Apologies, Tony, I keep interrupting you, but I'm trying to cover as many questions as we can from the chat. And I think in the meantime, Judy Wright, who is the information specialist in our team in Leeds and also in the different projects, also texted that sometimes systematic reviews end up with no included studies. So that goes the other way around. And that can be an important finding on its own right. So the next group of questions is...
Let me answer that. Let me say something small to that. That is very important because that 35,000 studies review that we retrieved, we ended up, none of the studies met the inclusion criteria. So all the work that we did, what now we do is that you just name it like scoping review. But in principle, it's also wrong to name it as scoping review in that sense after you have done it and you didn't find it. I will leave it as a systematic review, but with no evidence. So this is what funders will act on, because in their recommendation for research, you will recommend that this is important, but we did not find any study over there. So we encourage more studies, and funders will look at it and now make a call. That is what funders are going through, all of them. So scoping review is a review itself. So we don't finish systematic review, and if you don't find any study, you name it scoping review. People do. If you want to do a scoping review, it's like we want to scope and find what is in there. It's not a robust synthesis. And sometimes we don't even do the quality assessment because you want to just scope what is there and whether there's evidence that you can use. So that is the difference. But you can do a systematic review, a good one, but not finding anything. But still, it's a good systematic review.
Oh, that's really useful distinction, Tony. Thank you very much.
So it's a win-win. You don't do systematic review and lose. Whether you have findings or not, you still have something to report.
Indeed. Okay, so the next few questions are about quality and quality assurance. I think one of the questions was, how do you assess validity of systematic reviews? The related question was, what if the quality of primary studies reviewed in a systematic review is fairly low? How do you ensure the quality of the systematic review itself at kind of one level up as being good? So do you want to briefly kind of elaborate on these quality issues in systematic reviews? Over to you, Tony.
Yes, I would. I want to talk about them now. The quality issue is very important. And then, as I said, garbage in, garbage out. You said I showed a statement that what did it mean? It means that whatever you put, whatever you find, that is what will determine your systematic review. So your systematic review evidence is as good as the studies that you have found. If you did not find good studies, your systematic review cannot. It's somebody, one of my line managers some time long ago told me, you can't build Cascala on Rolls Royce. They are two different things. Because now, this is, you want the best evidence, but the studies that you want to include to make the best evidence, the studies are not there. There's nothing you can do. So just look at what you have. But we say that the quality assessment is a process. It is assessing the quality of the studies that you have included in the review, and at the same time, assessing the review process. So there are two ways that you will assess. The way that you conduct the systematic review, you yourself would introduce some biases which would now compromise the evidence, not necessarily the studies that you have included. But you can also, the other way around is that you do everything right, but you don't have the good studies that you don't have the good studies to include in your systematic review. But when it comes to that evidence assessment, tell them that, yes, that's why we rate. Sometimes the evidence level is moderate to low, sometimes low. It is not an assessment of the systematic review that you have conducted per se, but it is an assessment of evidence that you are reporting, you are telling us. When it comes to that level, a lot of people make that mistake, thinking that if they say the systematic review evidence is low, it means that we haven't done things well. No, it doesn't mean that. You have done everything right, but the evidence level that you want people to use is low. And there are so many reasons that can account for that. So that is the best way I can explain. It's a process. And that's why we attempt to minimize biases in the way we do the systematic review. It should be transparent so that you do something, the same thing another person does, and you only come when we have done ours and have completed. And now we see whether we got the same thing. So there's transparency in that. And once you have done all these things and done the analysis the way it should be, and then assessing the quality, whatever the level of evidence is, the result of the studies included. Yeah, so there's difference between the two.
Okay. Okay, that's really helpful. And I think related question was about the quality of evidence from the case studies. I think there was a kind of a question whether the case studies, because these are individual patients or individual interventions, whether they considered low quality within the kind of the broader spectrum of hierarchy of evidence. Yeah. And I guess from what you were saying, from the meta-analysis perspective, they're clearly much smaller scale, but they have slightly different value because they go in more depth. So in a way, it's just different perspectives.
Yeah, exactly.
Okay, so the last couple of questions were largely about kind of tools, approaches, techniques. One of the questions was that the systematic reviews are largely geared towards intervention studies. So picking them up and distilling and sort of making sense out of this. But were there any steps taken in adjusting, particularly the registration of the systematic reviews for the non-intervention studies? So if I kind of park these with you, Tony, and then the related question, or rather kind of related to the tools, was also a question whether there are any particular tools that help distilling people for the systematic reviews. So it's the search kind of software, for example, and various other tools. I think that's what's been made. That's what's meant. I think it was Ama Fenny texted. So, Tony, do you want to pick up on these two kind of registration of
the last one first, and then the last one first, but we will remind me of the first one. The last one is no, we don't have anything like that. Nobody forces you to publish it or to whichever journal you want to publish. But now, those pioneers in systematic reviews have now championed database that would now register all systematic reviews, but they are not enforcing it on everyone. They are saying that under normal circumstances, if you want your systematic review to count or to be one of the credible ones, please register. Why do we have to register? Because you said that we don't have to duplicate unnecessarily. That is the waste message. So if evidence shows that or during registration, a systematic review has already been conducted on the topic that you are doing, probably we advise you not to duplicate. Unless otherwise you have a clear justification that probably the evidence level and the process, the way that evidence was synthesized or the systematic review was conducted has some question marks. Then you want to do it better. Then that one is also a justification. Or you want to update. Probably what is there is not a recent review, it is an outdated one. You can do the same thing by now looking for new studies to include, to update the evidence. But the question is, if there is already a conclusion about that particular study, or because systematic reviews now reach conclusions. If there's an overwhelming evidence to suggest that this level evidence is saturated, so what we do is that those respond. Whatever new study we do, adding it to the study will not change the estimate. Then we don't encourage you to even do a new systematic review, although what is there, it might be updated, because you are doing it on the basis of adding new studies. But we are saying that adding new studies will not change the direction or the magnitude of the effect. Normally, we talk about the direction and magnitude. So these are the ways that we will advise you. But this, we have the PROSPERO, which is housed by the Center for Reviews and Dissemination. Yes, and which, if the young people are there, I think I was there when it was introduced. So I was part, I also did the piloting with them myself. So I'm familiar with the PROSPERO. That encourages every potential systematic reviewer to register your systematic review. And then if you register and you give the green card, then it give you a number that when you submit it to, they don't publish, PROSPERO will not publish your full systematic review. It is giving you an ID, like when you are doing a clinical trial, you have to, any journal, standard journal that you want to publish a clinical trial will ask you of that number, registration number. So most of these standard journals nowadays will ask you about that number from PROSPERO to know that you really registered before they go ahead to. Some of them keep strict measures or keep strictly to the rules. So if you don't have, or you didn't register in PROSPERO, they won't even accept it to publish it. So that is the guide that what people are using, and that is the checks that people, but it's not enforced on everyone. And some of these predatory journals can accept the journal that has been refused by, the paper that has been refused by a standard journal, and you can get it published all right. So duplication is still a big issue in a systematic review. And that is why now the challenge is we have to speed up overview of reviews. Because the same idea that we had to combine independent primary studies to produce a common estimate or a common evidence is being defeated. In a sense that now we have so many systematic reviews on the same topic, which are also reaching different conclusions. So if you are the policymaker or clinician, which one do you choose? You don't have the expertise and you don't have the skill. And even if you have the skill, you don't have the time to go through or to apply critical appraisal tools to assess the quality. You want to find evidence as is and use it. So we are defeating the very purpose and idea of doing systematic review. That's why we have to hurry and now move into overviews and overviews of reviews. But even that, if we don't put control measures there, at a point, we will still have to now do overview something that we use overviews as the unit of analysis because of duplication. So that is what I think. Yeah.
Oh,
so those on the platform should be, whenever you want to do this, please register so that you are on a safer, you are, at least you are cleared to go ahead to publish it. But the first question, I think I missed the first question.
I think you touched upon the first question. The first was most systematic reviews are largely about intervention studies. So are there any particular kind of shapes of registration that are for non-intervention studies? And I think you already mentioned that the shape of the PROSPERO and other registration platforms is relatively flexible. And there are increasingly kind of non-intervention reviews that are being registered, including from, for example, AMIPS project and response project that we're doing. So in a way, it's worth kind of going up on those platforms and poking around and just checking, as you have advised, Tony, for the various protocols that are already been registered.
Yeah, other people are working hard on these ones, but the whole thing is that what we are talking, non-interventional systematic reviews are the emerging reviews with emerging reviewing methods. Like qualitative, who would have thought, even just in 2010, it was still being debated. Qualitative, COCHRANE will not accept qualitative evidence anyhow. But now we come to realize that qualitative evidence can contribute to some of the questions that interventional reviews cannot answer. So gradually, so it's not that people are refusing. The people who are doing that are just small. And then therefore, so their contribution is now, they are now coming. So people who are interested in systematic reviews are, most of them are the intervention, because that is where systematic review started. I said it's in evidence-based medicine, intervention A versus intervention B. And all of them were also in meta-analysis. So now it is up to the other side to catch up. So the environmental people have now environmental network that they are doing environmental analysis. Some of them are qualitative, some of them are. CAMPBELL is doing a complex one with network meta-analysis and those things. We will talk about them. And then this one, the one that we are talking about, they are all doing different things, but they have to catch up now. And that is it. Because in the business world, those who are doing the business studies, sometimes I was following business administration, but I saw that they will only summarize people's books, but they are not using systematic review. But this one is applicable even in the deep business world, because you can now assemble all the opinions of others using a methodical, systematic, non-biased way to analyze, but it's not yet there. So it is evolving, and that's why it looks like probably they are not there, but at a point, they would reach the level of the intervention studies.
Oh, that's brilliant. Thank you very much, Tony. Can I also just highlight that Tony has kindly offered to engage after the webinar with colleagues with any follow-up queries, and he would be more than happy to provide further advice. So what I've done, I have just uploaded again the flyer for the webinar, the latest version, through the chat function. So do download this, save it somewhere where you can use it. So, you will see in the flyer, there is an email address for Dr. Tony. So please do liaise with any follow-up queries, and that would be a nice kind of continued relationship and continued advice, because capacity development is not just about one-off presentations and one-off webinars. It's very much a process, and certainly that would be a really good platform. Okay, so I think that's pretty much touches upon all the questions that were through the chat. Hopefully that was helpful. Unless there are any further burning questions from colleagues that we can possibly kind of wind down and close in a couple of minutes, but there are a couple of things that we need to say before we close down. So Tony, do you want to take your stop sharing your slides so we can see as many colleagues as we can through the names?
Okay.
Thank you very much. Okay, okay, so let me pause briefly whether there are any final questions, any comments, anything before we start closing down. So I can see there are various thanks coming through the chat, so that is good. And the webinar is very much appreciated, so that's as expected. Brilliant presentation, Tony. Okay, so no further questions or queries or comments, and thanks are still coming through, so that's good. So all is left to mention. Well, I've mentioned the offer from Dr. Tony Dansapia to engage in further advice and guidance on the systematic review. And I would also like to emphasize that this is the first in the series. So by the end of kind of this webinar, there is certainly not an expectation that everybody will come out as experts in the systematic reviews, but hopefully everybody is a bit more convinced that the systematic reviews are good things to do, not just because they are nice publications to have under your belt, but there is a genuine value in them. Within the two projects, but also various other projects where I think we will be gradually opening these up to further participants. We are planning to have more detailed kind of webinars zooming into specific steps such as screening, then data extraction, then data analysis steps in the systematic review processes that Tony has taken us through. So please stay tuned. If you would like to be kind of engaged, do reach out to Tony directly. But otherwise, we will also kind of be announcing further timing of further webinars in due course. So let me pause at this point briefly. There are various thanks are still coming through. Hopefully, Tony, you are picking them up. I'm not kind of zooming in the individual ones, but it's very appreciated. So can I turn briefly to you, Tony, for any final words, any final kind of concluding remarks from your side? Over to you, Tony.
Thank you so much. My final word was the take-home message I gave. The question has moved beyond why is systematic review important to why is it not a reality and how can we all work together to make it a reality and quickly. So I urge you, this is just a sensitization for most of you who have done systematic review before or who have followed systematic review seminars before. This might not be so much, this might not be interesting. But in all seminars, I always say, there's always one message that you can take home, which is the take-home message. I don't expect you to take everything home, but at least there's one thing probably you are going to take home. I urge you, the sequence, the next ones we will be doing will now take the stages one by one. And that's why we go into details, and this is why we are going to detail how do we do it. This one is just sensitizing about systematic review and the value. Then how do we do systematic review? This will be the stages. So I encourage you, all those who attended, don't take yourself out of the webinars. Please join the webinars, and by the time we finish, maybe in a few months' time, we're going to decide maybe every month or maybe 2 weeks, join so that we can do a systematic review. And if you don't have a systematic review topic, please link up with us. Try to identify a systematic review question so that whilst we guiding, you also be doing the systematic review alongside. It will help a lot. So I encourage you all of you to attend our next webinars. They'll be very interesting and hands-on. It's very good. Thank you so much.
That's fantastic. Thank you very much, Tony. Stay tuned. The further timing will be coming in due course. And with all of that, please put your hands together, both virtual and the physical, for the insightful, really engaging and brilliant presentation from our keynote speaker, Dr. Tony Dancer-Pierre. So thank you very much, everybody, and particular thanks to Tony. Well done. And